We have a fairly full agenda today. You may notice that I'm not Win Arias. Win is very happy about that. No, Win is actually visiting in Europe, receiving an award, I believe. And so I'm John Hanover. I filled in for him before. I know many of you, but he's asked me to preside over the session today. And I really look forward to this week's session. It jives well with my long-term interest in human genetics and the pathology associated with certain chromosomal abnormalities, particularly Turner and other chromosome disorders. So I would be coming anyway. So it's wonderful to be able to introduce two really great speakers. We actually have three speakers today, I learned, and Jessica will be starting us off. But I wanted to just say a few words about the two speakers who have agreed to speak to us today. The first is Diana Bianchi, and I met her today. I've been at the NIH a long time, but it's a really great treat to meet her because I know about her work. She's currently the director of NICHD, and I'm just going to give you I took crib notes. When you have people with this kind of experience, you actually need to have materials in front of you. So I'm going to just tell you quickly. She received her BA at the University of Pennsylvania and her MD at Stanford University, and did a pediatric residency at Children's Hospital in Boston, and then did a program in both genetics and perinatal development at Harvard Medical School. So this is really some people talk about double hitters and triple, but this is really a triple threat. Really remarkable training, and I look forward to Diana's talk. In the second talk, we'll be hearing from Dr. Allen, and I'm going to screw this up because I screwed it up with Bill today, but I would say Decherney. Okay, excellent. So very good. And Alan and I, we've had lunch several times, but once again, I look forward to hearing his talk. And Alan also has a remarkable background. He got his MD at Temple University, internship at the University of Pittsburgh, and then at Obstetric and Gynecology at the University of Penn. He's been long-term involvement with CHD, and I think you were also in London in an immunology venue. So once again, we have a remarkably broad group of speakers today. So with no further ado, I'm going to invite Jessica to come forth and give us a little preamble.
I'm Jessica Zoltan. I'm a REI fellow here at the NIH. So pregnant women in the U.S. are required to be offered the opportunity to have prenatal testing for the most common fetal chromosomal aneuploidies, trisomy 21 and 18. The risk of these aneuploidies increase as maternal age increases. Current screening for these conditions consists of measuring proteins and hormones in the blood, like AFP, inhibin A, beta-HCG, and estriol, and also performing an ultrasound of the back of the baby's neck called the nucleotranslucency. The positive predictive value of these tests are low in the general obstetric population. Today, we will discuss an emerging alternative sequencing circulating cell-free DNA maternal plasma. This is an example of a trisomy 21 karyotype. Here you can see the duplication or triplication rather of trisomy 21. To obtain a karyotype, an invasive procedure like an amniocentesis or chorionic villus sampling must be performed. These are invasive tests to decrease the risk of unnecessary procedures. Screening tests that have a low false positive rates are preferred. This is a meta-analysis of data in a high-risk obstetric population. This article was published in 2016, rather. Here you see the detection rates for Down syndrome, Edwards, and Fetal syndrome. As you can see, cell-free DNA has a very high sensitivity and specificity for Down syndrome, with slightly lower sensitivity for Edwards and Fetal syndrome. The positive predictive value ranges between 84 to 91%, and the chance of a false negative is very low. It is not 100% accurate and should not be used as a final diagnosis for positive cases.
Thank you, Jessica. Good afternoon to everyone. Thank you for coming. So today we're going to talk about a real case history. This is a case that I've been consulted on electronically. Then we're going to go backwards and sort of tell you a little bit about the science behind prenatal genomic testing. But this case is really going to be about the incidental findings that are being increasingly detected as a result of routine prenatal genetic testing for the common chromosome aneuploidies that Jessica mentioned. Then we'll get into the ethical issues, and I will also mention a summary of issues raised by the case. I've written on non-invasive prenatal testing, which is also known as NIPT, or non-invasive prenatal screening, or screening using cell-free DNA sequencing in the maternal plasma, as the vanguard of genomic medicine. We just had a conference last week between NICHD and NHGRI that spent 2 days discussing the implementation of genomic medicine in preconceptual, prenatal, and neonatal clinical care. And it's really the vanguard for several reasons. First of all, industry, rather than academia, has driven innovation. And in a very short period of time, this went from bench work, and then with the rapid availability of commercial genomic sequencing, it became implemented into clinical care. And because of that, tests that are currently being offered to patients have been introduced before clinical utility has been established. So it's kind of unusual that you would be offering tests without showing that they actually make a difference in terms of patients' clinical care. Furthermore, although there has been a long-term professional standard for offering this prenatal screening for aneuploidy, there hasn't been a long-term professional standard for offering, for example, sex chromosome aneuploidy testing, or testing for chromosome microdeletion syndrome, such as DeGeorge syndrome. So as the sequencing availability has become incorporated into care, now more and more tests are being offered prenatally. And there's also been an impact on the whole field of maternal-fetal medicine. So the fact that the screening is more precise and more accurate means that fewer women need to have these confirmatory tests. So if the non-invasive prenatal screen is negative for the common chromosome aneuploidies, most pregnant women stop there. They don't want to have a needle into their uterus. So the consequence is that already in the 6 or 7 years that the testing has been available, there's been a 60 to 70% reduction in the number of invasive procedures. So that has consequences for the field of maternal-fetal medicine in terms of training and clinical experience. And it also has implications for cytogenetic laboratories. They're not doing as many samples as they used to do. But an area that our laboratory is quite interested in, and by the way, I'm not only the director of NICHD, I have a research laboratory at the National Human Genome Research Institute. So we're very interested in the sequencing of these samples because, as I'll show you in a moment, when you do the sequencing of maternal plasma, about 90% of the circulating cell-free DNA is from the mother and 10% is from the placenta. So you're not really getting the fetal DNA, but you're getting the placental DNA as a proxy for the fetus. Okay, so this is a real case. I haven't seen this woman, but because I have written extensively on incidental findings, I get a lot of electronic consults. And it's a way for me of keeping in touch with my clinical side since I haven't yet seen patients in the clinical center. So this was a 41-year-old woman in her 4th pregnancy. She had 2 prior miscarriages, and she had a healthy 2-year-old child. And she apparently underwent this non-invasive prenatal testing in her prior pregnancy, and that pregnancy had normal results. This pregnancy, however, had a result that said there were no results. It's also known as a no-call result or a test failure result. Now, I'll show you what the actual result, here it is. It says no results. Let's see if this works, no results. They couldn't even determine the fetal sex. And I'll tell you about the fetal fraction in a moment. Now, what's interesting, it says no results due to a DNA pattern that cannot be interpreted by this assay. A repeat specimen is not indicated. So you can imagine how that's very confusing to both the patient and the physician. But also in this setting of test results, they say further genetic counseling with the option of comprehensive ultrasound evaluation diagnostic testing should be considered because of an increased risk of aneuploidy when there is a no-call result. So no results. Okay. So how do we get to this space here? So here's the fetus and here's the placenta, and the placenta is undergoing apoptosis, and a result of this is releasing large amounts of cell-free DNA into the maternal bloodstream. Both the mother and the fetus produce cell-free DNA from apoptotic cells. In fact, everybody in this room has cell-free DNA in their plasma. If you're not pregnant, it's either coming from your own bone marrow, or should you have cancer, it could be coming from a solid tumor. But the fetal DNA comes from the placenta. So the massively parallel sequencing is performed on this mixed DNA sample. We don't physically separate out the placental DNA. And the percent of fetal DNA over the total DNA increases as the pregnancy advances. But the average sample around the time of the first trimester or second trimester contains about 10% placental DNA. And you cannot distinguish, you sequence everything, you cannot distinguish between the fetal and the maternal DNA. And I say fetal, but I really mean placental. But the placenta is a proxy for the fetus. The only way you can be absolutely sure you're looking at fetal DNA is if the baby is a boy and there's a Y chromosome. So clearly that is not coming from the mother. So in one iteration of the technology, I'll show you what whole genome sequencing looks like. So unlike other situations where you may have to fractionate your DNA, if you're working with an organ sample, for example, the cell-free DNA is already fractionated. So it's in fragments, and the fragments are slightly different in size, whether it's adult DNA or fetal DNA. The sequencing occurs on these fragments, and really you only need to sequence the first 25 to 36 base pairs. And that is unique enough to then map the origin of that fragment to a particular chromosome of interest. So for screening for trisomy 21, you're interested in the ratio of the number of fragments that map to chromosome 21 compared to the number of fragments that are mapping to a non-target chromosome that is serving as a reference chromosome. So if the fetus has a normal chromosome count or is euploid, there should be a 1-to-1 ratio. Does that make sense to everybody? But this technique is so sensitive that if the fetus has trisomy 21, for example, there's going to be a slight excess of sequences that map to chromosome 21. And you will come, if there's a fetal fraction of, say, 10%, you'll come up with a ratio of 1.05 to 1. And that is enough to exceed the z-scores and trigger a screening result of trisomy 21. So the physician, who is a maternal fetal medicine specialist who contacted me, said in her email, "I'm very worried about cancer. The patient is not." Now I'll explain why she's worried about cancer. She also said, "I've reached out to the genetic counselor at the laboratory," so this is a commercial laboratory that did the test, "and a medical oncologist who had no idea what I was talking about." In the meantime, the patient herself, the pregnant woman, requested a repeat test from a different commercial laboratory. So the first thing I asked her about was, what's the fetal fraction? Because when the fetal fraction is low, it can trigger a no-call result. So what is the fetal fraction? In the plasma sample itself, you're looking at the fetal, which is really the placental cell-free DNA, over the total. And what contributes to the fetal is largely, as I said, apoptosis of trophoblast cells in the placenta. And what contributes to the maternal is the mother's hematopoietic cells from her bone marrow. And if she is obese, you also get a significant component of apoptotic adipose cells. Now, what influences the fetal fraction are gestational age. So there's more as the gestation increases. Also, if there's twins, a multiple gestation, there's not twice as much cell-free DNA, but there's like 1.5 as much. Also, with certain aneuploidies, there's either more or less than you would expect. The mother's weight influences the fetal fraction because, as I said, if there's more in the denominator due to her apoptotic adipose tissue, it reduces the fetal fraction. And at any given gestational age, so this is from a study that was looking at women at 13 weeks of gestation, they were looking at the percent fetal fraction in a group of women at 13 weeks, and it ranged from 2.3% to 30%. So within what's considered to be normal, some women have very low fetal fractions and other women have higher fetal fractions. So the answer was it was 12% in this case, which would be in the normal range. So a low fetal fraction didn't explain why there was no result. And fetal fraction is important because more test failures do occur here. The blue bars are failed tests. So these tend to occur at the low fetal fraction. And everybody's worried about missing a case of aneuploidy. Well, there are basically 3 different methods for non-invasive prenatal testing using cell-free DNA. One is the tag counting approach, which is what I showed you before, which is mapping the fragments or tags to specific chromosomes. Another one is the SNP-based approach, where you're looking for specific variations in specific chromosomes of interest, and then you're comparing it to generally the mother's white blood cells. And then the third is a different, really a microarray approach. I personally think the tag counting approach is the easiest one to explain, but in this case, the first test was done by a SNP-based approach, and the second test was done by a tag counting approach. And it turns out that there are differences in test failure rates according to the technology used. Now, people are very interested in the SNP-based approach and the target-based approach because they're much cheaper than the whole genome sequencing, but it's less likely to get a test failure if you're doing the massively parallel whole genome sequencing. The other thing is this presumed association or suggested association with aneuploidy in the setting of the test failure only has been recognized with the targeted and the SNP approach, not with the massively parallel approach. And this will all make sense in a few minutes when I show you some pictures. It does cause some clinical dilemmas because when you do get this test failure, most of the time it is recommended that the woman should go directly to a diagnostic procedure, such as amniocentesis or chorionic villus sampling. The problem is that those procedures can cause an unintended miscarriage. And I have to assume that this woman who's 41, who used IVF to get pregnant, many women in that situation do not want to have an amniocentesis because they don't want to take any risk that they might lose this very much wanted pregnancy. So she actually declined a procedure. And that's why she said, I'll have a test by another provider. And then these test failure rates are generally excluded from industry summary statistics. So sometimes the sensitivity looks better than it is. Now, I've been very interested in the false positive, the test failure cases, because of the fact that women do not necessarily understand that either if there's been a false positive or they're told that there's a test failure with an increased risk of aneuploidy, they decide right away that they want to go and have a termination, which is a no-no. It's very clear that they need to have confirmation. This is just a screening result. They need a diagnostic test. So it does not mean that there's the fetus or the baby has a chromosome abnormality, but it's been a big concern with this testing. I prefer to think of it as these false positive cases and the test failure cases are really an opportunity to generate new knowledge regarding maternal and fetal placental biology. So you're going to hear about some of the crazy things that we've learned about. So up to 2% of high-risk cases, some people say as high as 10%, are discordant. So that means that when you get a false positive result or a test failure result, and then you do the diagnostic test, the fetus is normal. The fetus has normal chromosomes, but you've got this wacky result. And it generally is due to confined placental mosaicism. Now, what's that? That's when in the placenta there is a chromosome abnormality that is not present in the fetus. So the fetus is normal. Parts of the placenta have mosaicism for trisomy 21 or trisomy 13. Not infrequently, especially with IVF, and this would be very much on my mind in the differential, was that it started out as a twin gestation, and one of the twins died. And the twin might have had a chromosome abnormality. And then the third thing is that there is a maternal abnormality. So a few years ago now, I wrote a commentary in Nature about the big problem with maternal incidental findings, because most women are not even counseled when they get this blood test that this could find out something about your own health status or your own DNA. So I was concerned about a lack of informed consent. I'm sure Alan's going to go into this a little bit. Amazingly, and John might find this interesting, we are picking up quite a number of maternal sex chromosome aneuploidies this way. So the traditional teaching is if you're a woman with Turner syndrome, you're infertile. But there are a considerable number of women who are Turner syndrome mosaics or women who have 47 triple X. And they are pregnant, so they are fertile, but they have enough DNA with the sex chromosome aneuploidy in their circulation that it throws off the fetal testing. In addition, we've learned about women who themselves are mosaic for autosomal aneuploidies. So it seems that trisomy 8 is the most common of those. So you wouldn't think if I counseled someone prenatally that their fetus had trisomy 8, I might give a worse prognosis, not knowing that now we've discovered all these women out there who are actually mosaic for trisomy 8 and they're perfectly normal. We also have found maternal microdeletions or copy number variants that throw off the bioinformatics. Again, I'll be explaining this. And we know of a whole series of maternal medical complications. For example, women with autoimmune disease, women with B12 deficiency, intrahepatic cholestasis of pregnancy. These are all conditions that the mother has that affects the quality of the DNA and either messes up the way the DNA looks on the sequencing pattern or reduces the fetal fraction. I'm going to go straight to cancer as one possible explanation because that's what the MFM was concerned about. This is a colleague of mine who's a Dutch geneticist who was joking around and said NIPT really should stand for non-intentional pre-symptomatic tumor diagnosis. And when I've talked to NCI, because we're very interested in working up women who have a false positive result due to the fact that it is a tumor that they have that's releasing DNA, NCI says, well, this is some of the most compelling data we've seen about the way a liquid biopsy functions. So it's an unintended liquid biopsy. So we've actually, my laboratory when I was still at Tufts, published on this. We did a study of 10 women, of whom 8 allowed us to retrospectively analyze their DNA. So these are all women who were pregnant at various ages, at various gestations. But if you look down here, they all had cancer. But what happened was when they had this type of testing, they either had test failures or they had multiple aneuploidies. So here's a woman who had trisomy 21, trisomy 13, trisomy 18, and monosomy X. That result would really not be compatible with a living fetus. She went on and had a fetal diagnostic procedure. The fetus was normal. All of these fetuses were normal. And at the time their testing was done, it was not known that they had cancer. So we put a call out for these types of women who had confusing results. And we heard back from these 8 cases that basically they were diagnosed with cancer after these confusing results. And these women gave us permission to retrospectively open up their DNA sequencing results to see what was really going on. Now, in the typical sequencing analysis, the results are blocked except for chromosomes 13, 18, and 21. So you only know that something is going wrong in those chromosomes and the counts mapping to those chromosomes compared to the reference chromosomes. And when you open up the results and look across the whole genome, what you see is genome-wide imbalance. So here are the 8 cases. In some of them, we had multiple samples. But case 3 was a case of colorectal cancer. And she was initially screened positive for trisomy 13. The blue, it's actually a very high peak, but we can't show it because of the scale here. So it's just the blue box means there's excess of chromosome 13. And the sample was repeated when she presented clinically after delivery with colon cancer. And basically all of her parameters were exaggerated. And then after treatment, she's completely clean. What this slide is meant to show is that there are multiple areas of imbalance that are being incorrectly interpreted by the bioinformatics algorithms, because the algorithms are just reporting on 13, 18, 21. So we know that cancer is a reason for false positive results. And this is a different case. This is a case from Michigan that I was involved in where, again, these multiple aneuploidies are crazy. This is monosomy 21, monosomy 18, monosomy 13, monosomy X. It's incompatible with life. And yet this woman also had a normal female fetus. And this is a little bit easier to understand. Her first sample, if you look at the green line, it's not that there's monosomy 21. 21 is actually perfectly normal. This is the identity line here. What you're seeing is trisomy of chromosome 8, trisomy of chromosome 10, trisomy of chromosome 20, and that is throwing off the bioinformatics algorithms. So so in this case, 13, 18, 21 must be using 8 and 10 and 20 as the reference chromosomes. This poor woman had a significant delay in her care, and it was many months later when she had a second sample. And you can just see how these peaks have changed over that interval of time, and that correlated with metastasis of her colorectal cancer and growth of metastases on her liver MRI. So there's interest in following this up, and one group in Belgium has recommended doing whole body MRIs, and we're hoping to be able to add this to a protocol here at the clinical center. But this case is not about cancer. The MFM jumped to conclusion. So in fact, the patient got it right because the patient said, I want my test done by another laboratory. So this was done by a different commercial laboratory that now, instead of just using the targeted approach, is doing the whole genome sequencing. And the test result is negative, meaning there's no aneuploidy. The test is not a test failure here. It's a female fetus. And, it's basically essentially a normal result at the 7 megabase level. So that's going to be important later on. You can see that this particular laboratory is not only looking at trisomies and fetal sex and sex chromosome aneuploidies, but it's also looking for any imbalances at the 7 megabase level and then specific microdeletions that are associated with clinical syndromes like DeGeorge, as I mentioned before. So it turns out that it doesn't say it on the result, but they did see something below the 7 megabase level, and they recommended that this woman have a karyotype done. And in fact, her peripherals, this is the mother's blood karyotype now, shows an inversion of chromosome 3. So the presumed explanation is the mother has an unbalanced karyotype at the DNA level. And if chromosome 3 was used as a reference chromosome for sequencing ratios, the results would be unusual and end in a no-call result. So that's what I think happened. But it's even more extraordinary because this woman was an infertility patient. So I just want to mention that false positive results due to maternal copy number variants, as I presume occurs in this case, has been reported as a reason for false positive results. So in the New England Journal of Medicine in 2015, there was a report of several patients who had false positive results for chromosome 18. And what this was were clinically insignificant areas of duplication of the DNA on chromosome 18 that was triggering a false positive result. So there are a number of teaching points from this case. As I said, the maternal and placental DNA are sequenced, so you're getting results on both. And these kind of unusual results need special expertise. So you need genetic counselors involved, you need maternal fetal medicine specialists involved, you need medical geneticists involved. A diagnostic procedure such as amniocentesis or CVS will determine the fetal status. Again, this woman didn't want that, but she could have had that, and that would have shown that the fetus was normal, and then you could work up everything else after delivery. But she did have a prior history, and maybe Jessica wants to comment on this too, but she had 2 miscarriages and an infertility history, and that might have prompted parental karyotypes as part of the workup prior to performing in vitro fertilization. The maternal inversion is recorded as apparently balanced on the report, but I suspect that it's unbalanced, it's slightly unbalanced, which you can find at the molecular level, but you don't see it under the microscope. So if the maternal inversion had been found earlier, it might have changed clinical care, and it might have alerted us to the fact that the non-invasive prenatal screening might have a problem, or we might have said, do the whole genome testing first. The other thing that was strange was the maternal fetal medicine specialist jumped immediately to cancer as an etiology of test failure, partly because it's more dramatic, but also she had had one other case, which was cancer. So she immediately went down that line and was talking to the patient about, I think you have cancer, when the patient said, I don't think I have cancer. So the entire differential diagnosis should have been considered. So that's my ethical framework. Does anybody have any questions while we move to, yes?
So the liquid biopsy.
Did everybody hear the question that the liquid biopsy for cancer is only about 20% sensitive for specific mutations like KRAS, I assume you're talking about. In this case, you're not looking for a specific mutation. You're looking for genome-wide imbalance. The tumor is undergoing apoptosis and throwing out a lot of cell-free DNA fragments, and that throws off the balance in these ratios. So it causes these unusual results. We don't know. That's one of the things we hope to study is whether you can actually, if there's a specific type of cancer, will you detect the single gene mutation, for example?
In the placenta, you have only 10% of the fetal genome.
Correct.
So
No, it's not 10% of the fetal genome. It's 10% of the circulating DNA is placental. It's 100% of the fetal genome is represented. And that 10% increases as gestation advances.
thank you.
Yes?
The person
question was, what kind of information does the obstetrician have? I assume Alan's going to talk about this a little bit, but I showed you the actual results. So that's what the test report looks like. And a big issue in clinical care is there's no standard for how these test reports are issued. So this is very, new implementation of genomic medicine, and there's still no standards. So that's what they get, and it's complicated, and you don't know necessarily what kind of genetic education the primary care provider has. So, yes.
Can the patients order the test themselves? Because you know that now people can go and take a test from CVS.
Yeah, that's an interesting question. So. To my knowledge, a healthcare provider has to offer these tests, and then either the patient signs a consent form or sometimes the provider signs the consent form.
I was just going to ask about something like Swyer syndrome, where it's a molecular defect.
Yep.
Is that part of the normal screening?
It's not screened, but it is. I actually have reported that as one case of false positives. So a different kind of false positive is when the genetic result differs from the ultrasound result. So in Swyer syndrome, there's a Y chromosome, so the result on the blood test would have been normal male, and then you go to the ultrasound, and it's a female fetus. And that happens more commonly than you would think. So I know at least one case where it was shown to be due to the fetus having Swyer. No, actually, sorry. In this case, it was the mother had Swyer syndrome, and she had egg donation. Yeah, so it was more complicated than that. So we made recommendations for a number of questions to be asked. Because if a woman needs egg donation to conceive, then you've got to start thinking about causes of infertility a little bit differently. Wow.
So
Yes,
just
Steve.
to clarify an earlier point, so you can sequence the mother's DNA from her own family. You can do that. And then, so is it possible to get a full sequence of the fetal DNA from the placental DNA and then separate out, because the mother is known, a full placental sequence and a full maternal sequence?
Yeah, so thank you for raising that question. So just to be absolutely clear, the sequencing for this non-invasive prenatal testing is only done for the purpose of mapping. You're not looking in this kind of testing that we're talking about for single gene disorders. So we wouldn't pick up sickle cell anemia, for example, this way. But of course, the field is moving forward, so there's great interest. Can you non-invasively sequence the fetus? And we're not there yet. It has been done in demonstration cases. There's one report that was in Science Translational Medicine. It cost $200,000 to do that one case. But there are, and I think Alan's going to be talking about this, there's a lot of interest in using diagnostic procedures to get pure fetal material, sequence that to determine the whole genome sequence of the fetus. So that's a whole other set of ethical questions where you have a fetus or a prenate, as we heard last week in this discussion. Sometimes people are preferring the term prenate, especially if you're going to do treatment on the fetus. If you have this fetus, do you want to tell the parents about all of the things that you find? And also, how do you interpret that sequence in the context of a fetus? We may not know what some of these mutations or variations mean.
So,
yeah.
In a lot of mammals, the placenta becomes polyploid, which has a very unusual cell cycle. So do you see any of these where you have a syndrome that's specific to the placenta, where you have genomic instability, which is very common in endocycles, and the fetus looks to be completely normal?
Well, moles, right? Molar pregnancy. So Alan's more of an expert on that than I am, but yeah.
Yeah, we have to use the mic because there's about 4 times as many people
But
hearing this.
Yeah, so moles would definitely have a very unusual triploid sequence, for example. But you would certainly see that on ultrasound. There are certain findings that you would see.
So based on the types of cancer that you show, most of the cancers were blood cancers like leukemia and lymphoma. Do you feel that that has to do with the fact that you're collecting the circulating DNA? So you're most likely to get certain type of cancers versus others. And then for the fetal fraction, if you're able to get some of the, I guess, the hepatocyte DNA, I just thinking of like colon cancer usually metastasizes to the liver. So my question is if these tests are most likely to capture certain types of cancer versus others.
Yeah, so we don't know enough yet. So we have our study, and then there was another study done by another group where they reported on, I think, 40 cases of cancer. Half of those were due to uterine leiomyomas, so fibroids that are probably undergoing malignant change. But we saw an excess of lymphomas, and I still think that lymphomas are at the top of the list because of just the age group. You know, these are pregnant women in a relatively young age. Yeah.
I wonder to what extent an active infection can skew the results, or the
Yeah, so that's a very interesting question. I don't know. I don't think I've ever really thought about that. But inflammation, you know, is going to change the blood and where blood is going and transport of different things. But you know,
do people look at that at all?
Not that I know of. No. So, be an interesting opportunity. Yes, Josh. So certainly there are more fetal cells, intact fetal cells in women who have preeclampsia because of the abnormalities in the placenta. There's such a variation in fetal fraction. We and others have done studies trying to sort of predict if you have a high fetal fraction, are you going to have more complications? But the data are not clear on that. And I'm not aware of a specific cohort that's been looking at preeclamptic women.
Okay, Justin, I hate to cut off this great conversation, but we'll have time after Alan's talk to answer more questions. Thank you.
Okay, great.
All right.
Okay.
And just so you know, when I was recruited to Tufts, Alan recruited me. So Alan was my boss, and now I'm his boss. So just be careful.
Thank you. Okay. Well, first of all, I have a disclosure. I borrowed these slides from somebody. Haley, it's picking up. This Haley Sullivan, who's in the bioethics division, gave a great talk about this. So I borrowed some of her slides with permission, and I will destroy them as soon as I give this talk. But what I want to talk about is the patient side and the physician side as far as this information is concerned. Because now these patients have this tremendous amount of information, and the obstetrician gynecologist, and they're having a great deal of difficulty in dealing with this information. You can see how complex the science is and how complex the information is that the patients and the obstetrician is given. Right. So just a little bit of the history about the prenatal diagnosis. It dates back to the 50s. And the first thing was ultrasound. Actually, it was still ultrasound. It wasn't real-time ultrasound. And then, although it says 1877, actually, amniocentesis, looking at chromosomes, was done first in Northwestern in 1966. And this was pretty much the standard until chorion-villus sampling came across, and that was done either transabdominally or transvaginally, where a small piece of placenta was taken off and analyzed. And this was all chromosomal analysis, looking mainly for trisomies or sex hormone differentiations. And now, of course, we're now in the era, and you can see how things have changed dramatically as far as cell-free DNA is concerned, and just a blood test. And of course, the patients are happy with that option because they don't do something that's invasive and has, even though a small risk of miscarriage, they still are concerned about that. Diana mentioned even IVF patients are even more concerned. So this has taken off dramatically as far as the patients are concerned. But then it set up a new standard or a new problem. And as far as the obstetricians, and we'll talk about that, it's education is the problem. And the patients, of course, it's the decision to go on with the pregnancy or to terminate the pregnancy. Okay. So what information do parents want to know about the fetus? And you'll see some patients want to know nothing, and some patients want to know everything. And of course, that's the ethical dilemma. And what do parents do want to do with the information? And you know, in my career, I've met many examples. I could just share one. One of my IVF nurses, when I was at Yale, had abscess of the corpus callosum, the ability to go across the brain, to go from one hemisphere to the other. It carries a 10% chance that the child would be markedly retarded, and a 90% chance that the patient would be, the child would be perfectly normal. You can see what a tough decision that made. She was older, an older woman. That was her only pregnancy. And what kind of guidance would parents like from the medical team regarding genetic testing? Recently, I spoke at the University of Pittsburgh Law School about this, and there were lots of genetic counselors, and they said there's no problem here because genetic counselors give patients the information that they need. That's not true. They give the patients information, but they come to the obstetrician or sometimes the pediatrician and want to know what to do with that information. So although they give them information, they really want the guidance from the physician when they have time, when the time comes to make a difficult decision. So as far as the patients, this was a survey that was done in this area. It was an online survey. The population was from actually Fairfield County. And there were Spanish-speaking women and there were English-speaking women. And it was a broad spectrum of patients as far as who was studied and what their results and what their feelings were. So this just looks at the demography as far as age is concerned. Obviously, the peak is between 31 and 40 when most women go on to become pregnant today. 20 years ago, it was 21 to 30, but things have shifted demography-wise. And you can see this looks at ethnicity in this group, and you're familiar with Fairfield County. It's equally divided between Hispanic and white, which really does represent what this county was like. And this looks at education, all spans of education, high school or less, and graduate degree. And you'll see these demographic profiles have a lot to do with the decision that the patients make, and this just looks at the income as far as these people were concerned. Now, how important is religion to you? And you can see that if you just cut the slide in half, religion is very important to this group of patients, and this becomes important because the bottom line here is to have an abortion or to not to have an abortion. And that's the decision that the patient really has to make at some point. But there are other decisions that have to be made, and we'll illustrate those in just a moment. So which categories of information would patients want from prenatal diagnosis? Well, they want to know about the diseases that patients, that the infant will die of in the first 2 years of life. And this is a pretty easy decision. And of course, in my field, a lot of these patients are screened out before conception even occurs by testing. Another is they want to know about the risk of childhood cancers, and you'll see why that becomes important over time. And they're interested in learning disabilities, and can this be predicted? Then the more common diseases, heart diseases, heart disease and Alzheimer's. I mean, this is kind of a spin-off of 23andMe, looking at predicting of things that are difficult to predict. They commonly occur in the population, but this was just a test to see how patients would respond if these things were possible as far as being diagnosed is concerned. And the critical piece, well, this is BRCA2 and Huntington's, but the critical piece is traits. Hopkins did a study a number of years ago, and then actually it was screened at the Stanford Law School, where I also spoke. And they had to prioritize genetic engineering. So the first was Tay-Sachs disease. The second was or muscular dystrophy. The second was BRCA2, and the third for breast cancer, screening for breast cancer, and the third was eye color or sex determination. And the public was opposed to eye color trait selection. And obviously, people in the audience, there were about 200 people in the audience. There were 5 physicians and 195 lawyers and social workers. And they couldn't decide about the patients with BRCA2, because if the baby's born now with BRCA2, 30 years or 40 years from now, when that breast cancer would show up, perhaps there'd be cures or there'd be something. So they couldn't decide on that. But then a woman got up who had a wig on, who obviously had breast cancer that was metastatic, and she said, I would do anything so that hell, her diagnosis, would be visited on the next generation. And that changed people's votes in the audience, and that they decided that fetuses should be screened for BRCA2, or actually prenatal, pre-infertility patients. So what categories of information would patients want information on? Red is they wouldn't want information, and you can see traits to look at that end. I think it's strange they wouldn't want evidence on Alzheimer's and Huntington's. Depends, I guess, on how they were counseled as far as that's concerned. But the last thing was childhood cancer and Tay-Sachs. There, of course, they would want to know because these are fatal diseases, not more subtle diseases. And there might be many reasons why they would want to learn this, but selected the single most important. And you can see, if you look at childhood cancer, they could prepare financially because the patient would have to be treated. And if you look at the other end, Alzheimer's, it's the same. If you look at things that were not so interesting, the people in the graph in the red spectrum, you can see like breast cancer did not have the same intensity as far as patients wanting to know. And then, would you ever choose to end the pregnancy? And of course, this is an obvious slide. The people that would choose to end the pregnancy are those people that wanted the most information, and that those people that didn't want a lot of information would not choose to end the pregnancy. And this is pretty much, you see this a lot in OB practice as far as just looking for trisomy 21, because many patients will say they don't want to be screened, because if the patient is going to be affected with trisomy 21, they wouldn't have an abortion anyway. They would raise the child, and of course you try to counsel them that it's helpful to know that the child will have that, so you could prepare for that. But many patients will say no, and in fact, only 75% of patients that have a diagnosis of Down syndrome will go on to abort. 25%, even though they know they have a Down syndrome child, will not abort that child. So what factors predict the amount of help that you can get? One is genetic literacy, and as far as counselors are concerned, they're probably very genetically literate, and certainly geneticists are very. But our question now is obstetricians. I'm an obstetrician, and they're the people that have to interact with the patient as far as this information is concerned. So what guidelines do the patients want? Do they want federal guidelines? You can see in this poll they did not want federal guidelines, but they did want the obstetrician to be capable of counseling them. So information generally wanted to prepare financially, medically, or psychologically was important to the patient. Stress and unwillingness to terminate are most cited reasons for not wanting the genetic information. So now let's jump to the obstetrician for just a moment. And actually, this I don't have to disclose so much because I helped Bayefsky do some of this polling. But this is a big problem for us, for obstetrician gynecologists, because we're not well educated as far as this information is concerned. I mean, the report that Diana showed was pretty easy, but we get reports that are complicated and difficult to interpret, and it's hard to counsel the patients. And you can see here where it says preparedness for returning genetic test results. The results are pretty grim as far as how comfortable obstetricians feel. And refer to genetic counselor for clinical. Yes, they use genetic counselors, but as I said, they provide information, but not help in making a decision. Will your practice have sufficient resources to interpret, communicate these results? And you can see, I think it's highlighted, that only a little more than 25% of obstetrical practices feel that they can handle these patients. So this is a real crisis. Now, it might turn out, which would be sad, that the field turns this over to the pediatricians who are more facile with genetic material. But for me, that would be a shame, because that would be the obstetrician giving away an important part of what the responsibility is taking care of patients. So now this started with Michelle Bayefsky and I, because the American College of OBGYN sent out a questionnaire to all the obstetricians, and it was, I don't remember how many questions there were, roughly 20 questions about genetic literacy and feelings about the genetic prenatal diagnosis with detailed material, not just chromosomes. And you can see that the scores were pretty sad, and this has not changed. There are courses, but the courses are not adequate to teach OBGYNs. So this is a critical problem, and you can see here, looking at the comfort range of physicians as far as counseling is concerned. They're comfortable with the old testing. They're not comfortable at all with the new testings. So what role should professional societies play in adoption of this? Certainly they have to embrace this. This is wonderful technology that gives us lots of information, but it's a problem because we're not educating our obstetrician gynecologists, and I'm not so sure that they understand the importance of this. So on that note, I'll stop, and if you have any questions for both of us, we're happy to answer more questions.
So if you have a question, either come to the mic, or I can, because there's people on video. So.
I also don't want to leave people with the impression that the only option is to decide whether to continue or not continue the pregnancy. Women are using the information, first of all, to help them decide where they're going to deliver. So if there is a genetic problem, for example, if it's trisomy 21, it's very helpful to know that, so that you deliver in a tertiary hospital where there is, for example, a pediatric cardiologist. So 50% of babies with trisomy 21 have congenital heart disease. If the woman delivers in a community hospital, then she will be separated from the baby. So we counsel women who are continuing their pregnancy that this is a benefit of knowing ahead of time. Plus, most women nowadays use the information to educate themselves. And it's kind of interesting, because the early adoption of non-invasive prenatal testing was not where you would think, on the coasts. It was a lot in the so-called red states. And women wanted the information because they wanted to know about their babies they had no intention of terminating. The other thing is, in our laboratory at NHGRI, we are working on prenatal treatment for Down syndrome. I realize the title included fetal treatment. And we have in a mouse model shown that apigenin, which is a naturally occurring compound that exists in leafy green vegetables and citrus fruits, if you give it to the pregnant dam from conception onwards, basically, that we can show that acquisition of developmental milestones is shortened in the mouse models of Down syndrome. So it's proof of principle that prenatal treatment, at least in a mouse model, is looking promising, is what I would say.
Questions?
How does the percentage of people who want termination depend on the availability of health care? So you compare Norway, Sweden, the United States. How does that inform the decision?
I can't answer that.
Well, you could do comparisons amongst different countries which have healthcare or non-healthcare available.
I don't know, and it's a big social question as well. So I don't know. Do you know the answer?
No, but I would say it's not so much the availability of health care. It's the microenvironment of the culture. Like Alan said, religion affects decision making. It's very different even next door neighbor Scandinavian countries. So Norway is much more conservative than Sweden. They both have very similar healthcare systems, but Norway, very few women terminate for a prenatal diagnosis of Down syndrome, whereas in Sweden, it's the opposite. You know, people ask me all the time, because I've been working in non-invasive prenatal testing for much of my career, you know, the big fear was when you move to a blood-based screening for the major chromosome aneuploidies, would that somehow make it easier for people to abort because they have fewer stages upon which to reflect on what the results mean? And there's now 8 studies that have looked worldwide about the influence of the cell-free DNA testing on the termination rate for fetal aneuploidies, and there's been no effect. In the United States, about 40% of women continue their pregnancies with a known diagnosis of Down syndrome. It's, you know, it's somewhat dependent on where you are. Like New York City has one extreme, Utah has another extreme, but overall it's about 40%.
Yeah, I'm sort of interested about the mechanics of the interpretation and what you would do from there. So I'm wondering, so in the survey, it said that maybe half of the obstetricians would just go to a genetic counselor. And so I've got 2 related questions. One is, why wouldn't you just do that all the time? Why isn't that a crutch that you could lean on all the time? And the other one is, what percentage of these tests are something that are not just covered by some FDA guideline or something like that, that you would feel comfortable saying, oh, here's the answer. I'm not a doctor, obviously. There's a chart somewhere in the doctor's handbook that says, go look at this. And how often is it that you really say, oh, I don't know what's going on and I don't feel comfortable with an answer?
Well, that's it. The second part is there is no handbook.
That's what I thought, actually.
But I would guess one of the cures for this, for the obstetrician, is that eventually when there's enough of a library, it'll be on, and you can go in and look up some of these things and come out with experience based on building a library. But this is relatively new technology, so there's not a lot of, and the flow is actually from the genetic counselor. You send the patient to the genetic counselor. The genetic counselor then informs them about statistics, and then they come back to the doctor, and then they want the doctor to help interpret, not help, really interpret that for them. And actually, you can see the difference between an obstetrician and a pediatrician, because
I'm a geneticist. I'm a
well, but you're a
geneticist,
pediatrician,
Yeah.
and you know she's interested in adapting the child, and we're interested in delivering the best baby possible for the couple.
So I just want to point out, none of these tests are FDA approved. They're all laboratory developed tests, number one. Number two, the timeline has been incredibly quick. So remember that you could only, an individual laboratory could only buy a massively parallel sequencing machine around 2008, 2009. That was when some of the large-scale clinical trials started. And the testing became available in the United States at the end of 2011. So we basically only have 6 years experience. So it's been the fastest growing genetic test in history. So it's really hard to educate people. So who's taken up the slack has been the companies. And that's been an issue. And, you know, the obstetricians then turn to the company representatives, some of whom may be genetic counselors, but maybe not. Maybe they're marketing representatives. They are providing the information and the statistics. So that's a little different from some other areas of medicine. Yes, are you a genetic counselor?
Me? No, I just have something to share with you all. I'm actually a medical technologist with Inova Fairfax Hospital.
Okay.
And I just like to say that this is really interesting because I'm down there in the lab, but 70% of diagnoses are made from lab tests. Laboratories have medical directors and pathologists.
Right.
Anatomical pathologists are the ones who actually make all the money. You know, if you have a uterine fibroid and you go get it examined by a radiologist, they get $600. A clinical pathologist in the laboratory gets $25 for giving a consult on anything they have to say about it. Now, what is developing, and this is with Dr. Mike LaPasada from Texas, is diagnostic management teams. So the laboratory is going to be developing the clinical pathologist who is going to be there for you as a clinician to interpret these lab tests, because there are so many lab tests now, like we're saying, the explosion of them, and the clinicians don't have all the answers. Certainly, the specialists do. If you go to a gynecologist, they're going to have those answers. They'll be able to interpret those lab tests and the geneticists. But also, the clinical pathologists in the laboratory, there are many of them that have great expertise in this. And so they're going to develop this thing called a diagnostic management team. And this is a little off the side, but say a patient comes in the emergency room and they're pregnant, but they also have lupus and they have sickle cell anemia. And now they have also a history of influenza A 3 weeks ago, and you're kind of worried about their pneumonia right now, and all, I mean, complicated cases. So this isn't something that can be covered by one specialty. So you have a diagnostic management team that is an orderable test. Right out of the gate, you have a meeting on Thursday. The laboratory puts together everybody, and you get on Skype. You get on the phone. The patient's walking down the street, they're on their iPhone. You have a meeting with everybody at the same time to go over what is going on with this patient and the interpretations of what is the correct test to order. So a lot of times clinicians don't even know what's the right test to order. They order the test, they get the answer, like you're saying, and they look at this, it says no result or no test. What does that mean? So you have everybody involved in the answer for the patient talking at the same time. Radiology, hematology, oncology, and you also have people at all different levels, not just the physician, but me who works at 10 o'clock at night in the lab that, you know, is looking at your blood and has answers. So I just wanted to throw that out there. That's something that's in the development.
No, thank you for sharing that. But that does remind me that the reports are signed by board certified, usually clinical molecular geneticists, which is a board certified specialty by the American College of Medical Genetics and Genomics.
So I'm curious in terms of at what time during pregnancy now the tests are carried out. So to a large extent, I think that the smaller can be the fetus fraction, which is still accessible for the good analysis.
Right.
The earlier it can be, you know, the earlier problems can be diagnosed, and the more women presumably will be open.
Yeah, so we say that really the earliest would be 9 weeks, but most people recommend after 10 weeks of gestation. So that's starting from the first date of the last menstrual period. The test gets progressively more accurate as gestation advances. So you can actually do the test the day before you deliver and get information. And sometimes that's helpful if you see something unusual on ultrasound and you want to manage a case. Let's say that you think that it's trisomy 18 and now you have to decide, would you do an emergency cesarean section on this woman? You'll use that information. And it should be accurate even late in the pregnancy.
Do you see regional differences in the fail rate, which might suggest that you're having quality controls in some of the laboratories?
No, it's not that. I think it's really more related to the specific technology.
Okay.
It's not regional, although so between 2011 and 2015, all of the tests were done essentially by 6 major commercial organizations. So Sequinome, Illumina, Natera, Ariosa, and then 2 companies in China, Berry Genomics and BGI. And then what happened was in 2015, those companies started to sub-license to other laboratories. So when the big 6 were doing it, they had experience in hundreds of thousands of cases. Their quality was generally very good. But as they began to sub-license it to other smaller laboratories, then with less experience, laboratories began to have some difficulties.
What determines the rate of placental apoptosis?
You want to answer that? So I thought at one point that it was related to. We thought it was related to volume. It would make sense that it's related to volume, but it's not. We actually did a study looking with ultrasound to very precisely measure, maybe not by today's standards, this was done maybe 8 or so years ago, but we tried to correlate placental volume with fetal fraction. It didn't correlate at all. So I do think it's a marker of placental health, and that's why your suggested study about preeclampsia would be a good idea.
And also, are there any known genetic changes that occur upon, for example, the syncytia formation in the placenta?
So it's a matter of fusion, I don't know that anybody's really looked at the underlying mechanism behind confined placental mosaicism, other than it's usually a post-fertilization event. But are there other factors that are promoting that? I don't know.
How about we see mosaicism in our embryo biopsies. Right. So how's that going to reflect in the fetal DNA?
So that's a great question, because it's a big issue now in IVF. Do you transfer a chromosomally mosaic embryo? And I mean, you tell me, but I think the usual wisdom is obviously you're going to transfer a euploid embryo first. But what if that woman is 43 years old and she only has three embryos left, or 1 embryo left that has a chromosome abnormality? There's increasing discussion now as to whether you should transfer that embryo or those embryos. And so what we're finding in this workup of these unusual false positive results there are rare trisomies that I, as a pediatrician or geneticist, never thought was compatible with life, or certainly not with a pregnancy that would get up to the 3rd trimester. So we're increasingly seeing these unusual trisomies, some of which are just in the placenta. So that, we don't know. Some of those might have been mosaic embryos if we had known, if we had biopsied them. So I think that a lot of the conventional wisdom, for example, the fact that women with Turner syndrome are infertile all the time, or these rare trisomies are not going to make it through the pregnancy, all of that is being questioned by this technology. Ben, you look concerned. You've been very quiet.
You can spit your stuff.
So how many tests and who is paying for it? And how much does it cost?
Okay, so how many tests? There have been somewhere between 4 and 6 million done since 2011. I actually kept count. I had good relations with the 6 companies, and they gave me their numbers once they were publicly released, so we could get an idea of what was happening. But when it became disseminated globally, we lost track. So we can only estimate now, but it has had a significant impact on practice. The The way it's handled in different countries is different. So in the United States, it's all over the place. If you're high risk for a fetal aneuploidy, so if you're over age 35 at the time of delivery, if your fetus has a major sonographic abnormality, if you've had a previous child with a chromosome abnormality, or if your serum screening or the nuchal translucency test look abnormal, most insurers in the United States, including some state programs, will pay for this test. What it costs, it's all over the place. The state of California will offer you everything for $207. It can be up to $1,000 in other places. But what's really interesting is the way other countries are doing this. So the big debate is whether to offer this to all pregnant women or just women at high risk. We just showed you the data, the meta-analysis data. Jessica showed you that in the third slide on high-risk women. But at the end of the day, and we published on this in the New England Journal of Medicine, this performs much better as a first-tier test. So it's 10 to 20 times better than the current standard of care. Why not offer that to everyone? Well, it's more expensive right now, but certainly we expect those costs to go down. There's education issues, there are counseling issues. We don't have enough genetic counselors. That was the answer to one of the other questions. We just don't have the workforce capacity. But in smaller European countries like Belgium is offering it to all pregnant women as a first-tier test as part of their National Health Service, no extra charge. The Netherlands is comparing just focused trisomy 13, 18, 21 results compared to everything. In the UK, they're going to offer it as a secondary screen as part of the National Health Service to women at high risk. So it's a little bit all over the place. But everybody agrees that it is for sure the most accurate screen for Down syndrome. Yes?
Interpretation and the treatment from them, So
how's the interpretation in Belgium? I'm probably going to hear about this soon because I'm going to a meeting, how it's going there. But in Belgium, they have a bioinformatics algorithm that's publicly available called WISE Condor. And so they are looking at all of the chromosomes. And I believe they are reporting on all of those results because a lot of the explanations for the false positive cases are coming from Belgium. So I don't know exactly their study design, but I believe that they're reporting on everything. Yeah. Well, in a smaller country, they have well-organized centers of expertise, and those are the groups that are responsible for both standardizing the reporting of the results and educating their physician workforce.
I guess it's a two-part question. Thinking back to the issue of cancer that you described, you could get a baseline either preconception or very, very early in pregnancy, and in theory those things, those anomalies would be there even at that early stage. So is that something that's being talked about? And the second part is, are there segments of DNA from a prior pregnancy that stick around?
Okay, so let me answer the second one first. So the cell-free DNA is from the placenta, and if the placenta delivers normally, like there's no retained placenta, then most of it is gone within 2 hours of delivery. So I think it's fairly safe to say that Princess Kate doesn't have any Y chromosomal DNA circulating from the latest baby. But if there's a retained placenta, or we've actually studied in the case of medical terminations where the expulsion of the placenta was not complete, you definitely still see the Y chromosome sequence if it's a male. The first question was about the cancer. Would we? Yeah, I don't think we're there yet. I mean, we're basically right now at a very early stage where we we want to understand, are there specific patterns in the DNA sequencing that would lead us towards a cancer workup versus something else, and also understanding what's going on with fibroids.
But it's such a low-risk group.
You mean in general, this
Well,
pregnant
you're talking
women?
about prenatal
Yeah,
scanning
right.
to rule
So-
out malignancy. I mean, it's such a low incidence group of people.
Yeah, it probably wouldn't be an appropriate use of resources. But once you see that sawtooth pattern, that's what we're interested in.
And Diana, technologically, do you see a convergence on short reads, Illumina type, short read, shotgun sequencing, or there's a big push for longer, higher read depth and longer reads, the MySeq type. Do you see
Right.
a convergence on the short reads? I can see some advantages to the longer read technology.
Yeah. I'm not in the commercial labs, but I know that they're looking both at increasing precision, but also reducing cost.
Yeah.
So there are some labs that are looking at benchtop approaches. If you're just interested in 13, 18, 21, there's the possibility of more rapid benchtop approaches.
Yeah, and for us, the IVF stuff, they look for 200 diseases specifically, and that's what they look for besides aneuploidy.
For your test, do you see any difference in terms of with patients with, let's say, placenta creta or previa, any of the placental abnormalities? Do you get a difference in terms of the results?
Yeah, so unfortunately, the commercial labs that truly have data on hundreds of thousands of cases, and I've collaborated with some of them to get information, they're not getting the kind of richly detailed obstetrical histories that we would like to interpret that. Even something as simple as fibroids, which are much more common in African American women, they're not even capturing race. So it's very hard to know, because I've been asked, is it more common? Would you expect more commonly a false positive result in an African American woman due to the very high prevalence of fibroids? And the labs, I don't know. So that would be another reason to do a research study.
Okay, if there are no further questions, let's thank both of our speakers today. And I assume they may be around for a few minutes to answer additional questions.
Yep.
So thank you.
So all the tests are now